The glabellar V to Y sliding flap is one of the options for repairing a medial canthal defect. Here a patient has been brought back having had Mohs surgery with a defect that goes from the upper lid to the lower lid through the medial canthus. There are a number of potential ways that this could be repaired, but this technique shows a standard glabellar V to Y flap. The first step is still to minimize the size of the defect and minimize any residual laxity in the lower lid by pulling the lateral residual portion of the lower lid across. I'm using a 6/0 vicryl suture to do this. You could also use a 5/0 vicryl depending on how much tension was placed on the suture. Here my assistant is gently pushing across with his finger, and essentially you need to judge the tension to check that what you're trying to do is realistic without the suture simply cutting out. And of course your experience from doing a wedge resection and your experience of how much you can tighten a lower lid very much comes into play. This first suture is then supported with some further 6/0 vicryl sutures, here with the knot placed upside down, pulling the tissues again closer together. Again, it's very nice to have an assistant to ease the tissue across as you tighten and lock your knots. And again, you can see how each knot holds to give you an idea as to whether you have an acceptable tension. And this process continues until you're happy that you've placed the lower lid in the best possible condition and overall reduced the inferior portion of the defect and brought the tissues back together in as sensible a fashion as you can. Interestingly, at this point, the overall size of the residual defect is actually quite small, and two alternative options to the VY flap would be either a skin graft or indeed a laissez-faire technique. If a hole this size was simply allowed to granulate, because the scarring would pull centrally, the overall tightening of the lids would all be in the correct direction. Cosmetically, the scarring may not be ideal, but often cosmetically a graft doesn't look that good in this position either. The difficult decision, of course, is that both a laissez-faire technique and a graft would simply give a scarred area within the area of the defect, whereas the sliding flap takes some scarring in between the brows and has the potential of pulling the brows a little closer together. You can see in this instance that the sliding flap, however, is very tempting because this patient's natural frown lines are demarcating the position of the dissection of the flap, and therefore the scar here will be very easy to hide. The other benefit of the VY sliding flap is that if it extends into the lower lid, because its natural direction of pull is from a more vertical position, it helps to provide some vertical support to the medial aspect of the lower lid. In order to improve the cosmetic result, an extra piece is being taken out here, as this would otherwise give a dog ear as the flap was moved across. And with local anaesthetic allowed to take effect, the dissection of the flap is actually very easy, as this is a very nice plane to dissect through. The skin on the brow is a little thicker than elsewhere, so you can be a little bolder with your scalpel. And of course, you need to cauterize as you go along in order to maintain an optimal view. There are various techniques to perform this subcutaneous dissection. I still very much like the spring scissors, as I feel I can both push and separate as well as nibble. Some people feel very comfortable with the scalpel, others feel more comfortable with more blunt dissection with the larger scissors. But so long as you progress in the correct plane, and so long as you keep stopping and checking that your graft is the optimal thickness, there's absolutely no reason why any one technique should be particularly better than another. It's a case of having a feel and seeing what you're comfortable with. As the flap starts to move, make sure you release underneath all the corners to get the best cosmetic result and the least amount of unusual lumping of the tissue as you try and make the skin move through a 60-degree angle. Sometimes this extends the flap further than you might originally think, but again, as long as you create the flap carefully, this should be nothing to worry about. And again, check to see whether your flap is going to cover your defect. And here it is starting to move quite nicely now. The next step is to anchor your flap with a few cardinal sutures. And the first here being done with, again, a 6/0 vicryl is the turning of the V into the Y by closing the upper portion of the V. Again, the assistant demonstrating the movements about to occur, and then the tip of the flap is anchored down into the defect on the medial aspect of the lower lid. Now at this point, the flap could well tent up and not lie nicely down towards the insertion of the medial canthal tendon, and so before placing any other sutures, a very important suture is placed going through the flap, taking a solid bite of the insertion of the medial canthal tendon, and then coming back out through the flap about 2 or 3 millimeters superiorly to the entry point. This suture will then eventually be pulled over a bolster and will help tuck the central portion of the flap in down tight. The excess skin of the flap is now trimmed off. You can mark this with pen, or you can do it directly with the scalpel. or indeed half scalpel, half scissor. The idea is, of course, that the underlying edge of the defect provides you with a perfect template. And despite my efforts earlier on to try and avoid having a little dog ear in this corner, you can see that I was unhappy with the cosmetic result and trimmed off another small triangle in order to help the skin lie a little flatter at this point. With everything in position, you're ready to close the flap, and two of the key sutures are the position of the flap where it engages with the lower and upper eyelid, and I tend to place these first. And then the next step is the bolster. This is the severed head of a Q-tip, and you simply pass the needle through it just to take a little bite, and then slide the Q-tip down one arm, place a double throw, and again ask your assistant to press down firmly on the Q-tip such that you can then lock the suture. In this position there are other bolsters you can use, but the curved end of a Q-tip has proven to be absolutely perfect. To close the skin edges then, I've simply used a running 6/0 Prolene, and all these sutures are going to be removed at a week. The last thing that remains is to put some chloramphenicol ointment all the way along the scar, a little extra around the bolster and some on the eye, and then place a gelinet and pad, normally not for long at all, but just till the next morning. As I said, the sutures will be removed at 1 week.